adjusted outcomes of Rigo Cheneau versus Boston style orthosis in adolescent idiopathic scoliosis. Fasciana.
All right. Good afternoon, everyone. My name is Jonathan Fasciana, and today we're going to be talking about the adjusted outcomes of Rigo Cheneau versus Boston-style orthosis in adolescent idiopathic scoliosis. I want to thank SOSORT for allowing us to present our research. We have no conflicts of interest to disclose. So Boston and TLSO braces, these are the traditional Boston braces, were developed in the 1970s in Boston Children's Hospital. They have a hard shell with adjustable pads. You can see here in the picture. Rigo Cheneau braces were developed in the 1990s by Dr. Rigo and Dr. Cheneau. They are more individualized, and they can also have derotational forces to help the patient grow into a correct posture. Bracing is one of the chief non-surgical treatments for scoliosis, and some research has shown that Rigo braces do have a slight edge over Boston braces. This is the MINT study I'm referencing, and our study seeks to expand upon the study with our large clinical database. Our inclusion criteria for the study was based upon previous SOSORT guidelines and other literature. So previous research has shown that curves under 30 degrees will tend to stay under 30 degrees. This is from the Weinstein study and Hague Clinic data. So if patients are able to finish skeletal maturity under 30 degrees, they have less than a 5% chance of progressing in adulthood. We call this the green zone. Our hypothesis is that Rigo braces will outperform Boston braces even when controlling for other covariates for the following outcomes. Number one, avoiding surgery. Number two, avoiding curve progression more than 5 degrees. And number three, having a final Cobb angle of less than 30 degrees. We also expect stroke PSSE to be a major factor in this. Our data was collected from our local EHR called Aqueduct with patients from 2005 to 2024. From this, we collected over 40,000 patients, and we narrowed it down to around 9,851 patients with scoliosis x-rays, bringing it down to those who had an orthotist appointment, making sure that they were between the age of 10 to 15 at the onset of bracing, that they had a start curve between 20 and 45 degrees, that they were under risk of 3, and that they were braced for at least 6 months to skeletal maturity or surgery. So this left us with a grand total of 135 patients, 28 Boston and 107 Rigo that were included in our study. So when we look at our samples, we see that the groups are pretty similar except for 2 key factors. Number one, the amount of patients who had stroke PSSE for Rigo was much higher than for Boston. And number two, we saw some slight differences in the BMI and starting age. We will control for these later on in our multivariate analysis. These graphs show the scatter plots for Boston and Rigo patients over time. On the x-axis, we see age, and on the y-axis, we see Cobb angle. We can see curve progression over time. If there's an X, that means they had the surgery. As we can see on the left, Boston patients tend to trend upwards towards surgery, and Rigo patients tend to be more level. Although some had surgery, many of them had correction. When we look at curve angle progression, Rigo patients progressed around 1.1 degrees, and Boston patients progressed around 9.42 degrees. This is not controlling for anything. This is an 8-degree difference, and we can see the box plot here down below. When we look at the amount of patients who progress to surgery, 57% of Boston patients progressed to surgery, while only 30% of Rigo patients did. This is a 27% reduction and a 48% relative reduction, cutting the surgical rate almost in half. The number needed to treat for this is 4. All right. When we look at those who finished Cobb angle under 30, only 4% of Boston patients did so, while 42% of Rigo patients did so. This is for under 40 and under 50. Cobb angle progression under 5 degrees is also significant. We see only 18% of Boston patients finished under 5 degrees from their initial curve, while 70% of Rigo patients stayed within 5 degrees of their initial curve. We also looked at curve correction, where only 7% of Boston patients finished with curve improvement, and 39% of Rigo patients had curve improvements. We ran an ANCOVA wanting to control for other factors, showing that Rigo braces are associated with almost 6 degrees less curve progression than Boston patients. This is true even when controlling for start curve, start age, time braced, and stroke PSSE. We also use logistic regression to plot the odds ratios on a box plot. We controlled for Rigo brace, having PT, time braced, and initial age. We saw significantly positive odds ratios for Rigo braces for avoiding a surgical consult appointment, avoiding a surgery, final curve under 30 degrees, final curve under 40 and 50 degrees, progression less than 5 degrees, and curve improvements. So this leaves us with a few key conclusions. Number one, Rigo braces are associated with much less surgery, almost half the surgical rates, 30% versus 57%. Number two, less curve progression. When controlling for other factors, Rigo braces progress almost 6 degrees less than Boston patients. And with PT, this gets closer to 8 degrees. And number three, we saw that more Rigo patients finished in the green zone. Only 3% of Boston patients did so, while 42% of Rigo patients did so. So we had some limitations. This is not a randomized controlled trial, it's a retrospective study. And the Schroth PSSE difference was large for Rigo versus Boston. Boston's sample size was a little bit small, and this is a single clinic study. Also, some of our older compliance data was self-reported, making it not as accurate. For future research, we want to look at compliance and patient satisfaction, as some people say that Rigo braces are more comfortable. Number two, we also want to look at the combination of Schroth and Rigo braces. We also want to improve our screening so we can catch more patients in the green zone, because if you're catching the green zone, you can stay in the green zone. Number four, long-term follow-up. We want to follow up with these patients many years after they're bracing and have Schroth. Here are our references. Thank you so much for your time.